Good morning and welcome to Grand Rounds. My name is Bo for those I haven't met, and today I'll be talking about the management of pulseless electrical activity. So before I start, I just want to thank the following people. George Mastoris, my main supervisor, Mike Ho, Nick Costain, Rajiv, Mike Austin, and Crystal Chan. All these people have been influential in helping me prepare for these rounds. I'm not nearly smart enough to come up with all these ideas by myself. At the same time, if you disagree with anything I say, these people are partly to blame, especially George. I also like to thank all the people who responded to my survey that I sent out. 90 people in total responded out of a possible 150 or so, so it was like a 60% response rate, which is really good for surveys. And over half, about 56%, were staff physicians. So we own cardiac arrest. We are specialists in emergency medicine. We are experts at resuscitation, and no one sees as much out-of-hospital cardiac arrest as we do. The outcomes for out-of-hospital cardiac arrest, unfortunately, are still not very good. So overall survival to hospital discharge for all comers is about 10%, and for those with non-shockable rhythms, it's about 6%. If we're looking at survival with good neurologic function, overall about 8%, and for non-shockable rhythms, about 4%. If we're looking at outcomes specifically for PEA, the survival to hospital discharge, depending on the source you look at, anywhere between 5 to 8%, and then survival with good neurologic function, anywhere between 2 to 6%. So to be very optimistic, we can say about 1 in 20 patients with PEA will have a good outcome. For those of you who are more visually inclined, that's what it looks like. So I think we can do better than that. Is there any other disease state where a 95% mortality is acceptable? Now, at this point, some of you might be saying, well, these patients, when they come in, they're already dead. But that's the paradigm that I want to change today. So these are the points I want you to go home with at the end of the talk. PEA is a spectrum of disease. POCUS pulse check is a useful adjunct to manual pulse check. Cardiac POCUS is an essential initial diagnostic test. Arterial lines help guide your management of PEA. And consider alternatives to giving 1,000 micrograms, and yes, 1,000 micrograms, not 1 milligram of epinephrine boluses in PEA with cardiac activity. So we all know PEA as this rhythm on the monitor with no palpable pulse. And what we know as PEA was originally described in the early 1980s, and it was originally called electromechanical dissociation, or EMD. And the underlying pathophys was such that there was electromechanical decoupling of myocardial cells with no myocardial contractions. Don't ask me what decoupling means, but the key here is that there's no myocardial contractions. And this actually later became to be known as true EMD, because later on there emerged a phenomenon of what was called pseudo-EMD. So this was a paper published in 1992 by Norm Paradis. He was a physician at Bellevue Hospital in New York. And interestingly, Manny Rivers was also a co-author on this paper. And basically what they did was they took patients who came in with cardiac arrest, and for all of these patients, they put in a 60-centimeter catheter placed in the aortic arch by guide wire technique through the femoral artery. And apparently this was standard therapy during cardiac arrest in their department at the time. And what they found was there were two groups of patients. There was one group where there was electrical activity, but there wasn't any aortic pressures. So they called those patients the true EMD patients. And then the other group was they had electrical activity and they had aortic pressures that they can detect. And so they called those patients pseudo-EMD. So this is what it looked like. You can see clear aortic pulsations that correspond with the QRS complexes on the ECG. And so in their paper, they go on to say the data emphasize the inaccuracy of diagnosis based solely on the ECG and physical exam findings. In many patients, EMD is apparently not cardiac arrest, but rather a state of severe cardiogenic shock. Now, Paradis writes cardiogenic shock here, but really any kind of shock can cause PEA. So that's one of the main concepts I want to talk about today, and like Paradis said, not all PEA is cardiac arrest. And PEA is really more of a spectrum of disease. And so if you imagine a spectrum where on one end you have a patient who is dead, and on the other end you have a patient who is alive, PEA represents everything in between. And so there's a lot of terminology that gets thrown around about this. You've heard of true EMD or true PEA, where there's electrical activity but no myocardial contractions. On the other end of the spectrum, we have just hypotension in a patient who's very much alive, and you may or may not be able to palpate a pulse. In the middle, we have pseudo-EMD or pseudo-PEA, where the patient looks like they might be dead with no palpable pulse, but there's electrical activity, there are myocardial contractions, there's probably a decent end-tidal CO2, and there's probably a blood pressure that you can detect with an arterial line. And so some people have said pseudo-PEA should really be considered as profound shock or end-stage hypotension. Now, someone we hate to love or love to hate, Scott Weingart, he made up these terms: pulseless rhythm with echocardiographic standstill, and pulseless rhythm with echocardiographic motion, or PRES and PREM. And he made up these terms in an effort to clarify some of the terminology, but in my opinion, he might have just made the semantics a bit more confusing. But in any case, just know that a lot of these terms refer to the same thing, and they all refer to different states on the spectrum of PEA. So how do we place a patient on this spectrum between being dead and alive, and how do we draw that line? Well, the most basic and standard way that we know of right now is to palpate for whether or not there's a pulse.
The fingers you have used to dial are too fat. To obtain a special dialing wand, please mash the keypad with your palm now.
So let's talk about manual pulse checks. So this is perhaps the most basic and one of the most important skills in cardiac arrest management. Now, were you guys ever trained on how to do a pulse check? Because I wasn't. And it kind of seemed like to me that the day I started residency was when people started believing my pulse checks. And remember that the diagnosis of PEA hinges on your pulse check. So in other words, the sensitivity of your fingertip, or as some people might call it, your digitometer, is what determines whether someone is dead or alive. This was a study of paramedics and paramedic students, and what they did was they brought them into cardiac surgery ORs of patients who were getting CABG. And so some patients were on pump and they didn't have a pulse. And some patients were not on pump and had a spontaneous pulse. And so they asked the paramedics to go in to assess these patients. They gave them 60 seconds to check if there was a carotid pulse, and they were blinded to whether or not they actually had a pulse. And so the main findings from this study were that 45% of the participants assigned to pulsatile patients said there was no pulse. And more concerning, about 5% of participants assigned to pulseless patients said there was a pulse. This is another study of healthcare providers assigned to check the pulse on mannequins. And they were given 10 seconds to check for whether there was a carotid pulse. The mannequins, it sounded like, were very similar to the mannequins that we use for SIM, where we can simulate a pulse that you can palpate. And the most significant finding from this study was that 42% of the participants assigned to pulseless mannequins said there was actually a pulse. And so this is really our worst case scenario, right? We have a patient who's actually truly pulseless, but we might think they have a pulse. And so some smart people have been coming up with ideas how to help us detect whether or not there's a pulse, and this is what's been coming out recently. And this is the POCUS pulse check. And so this was a case series published by Rob Smart and Jordan Schenken from Toronto. And basically they describe a technique where you just place your linear probe over either your carotid artery or femoral artery and check to see if the vessel is collapsible and check to see if there are pulsations on the vessel. And they describe a series of cases where they do this and it changes the management of their cardiac arrest patients. For example, one patient was an 80-year-old guy who came in with PEA. There was no pulse by palpation. They put the probe on his femoral artery and found that it was non-compressible. There were active pulsations. So at that point, they paused CPR. They started a dopamine infusion, and then a few minutes later, they were able to have a palpable pulse. The patient went to ICU, and 11 days later, he was discharged from hospital, neurologically intact. This was another study out of Toronto, and our very own Alex Coutan is one of the co-authors. And basically, they looked at, they took healthcare providers and they assigned them to check the pulse of live people, like live models, either using POCUS or manual palpation. And what they found was the mean time to find a pulse with ultrasound or manual palpation was about the same. People assigned to the ultrasound group were more successful on the first attempt. Now, obviously, all the live models had pulses, and the healthcare providers weren't blinded to that. So this is really more of a proof of concept study to show that this technique is feasible. This was another study out of Turkey where they took real-life cardiac arrest patients, and there were 3 physicians who were involved. And the first physician did a manual pulse check. The second physician did a cardiac ultrasound. And then the third physician checked the pulse with ultrasound with Doppler. And all 3 of these physicians were blinded to each other. So the way they did this was actually very interesting. This is the diagram that they provide in their manuscript. And they say a specially designed curtain system was used so evaluators would not be able to see each other. It descended from the ceiling and divided the body into 3 sections. So how they managed to run the resuscitation, I'm not sure. But they did a really good job of blinding. Anyway, so these were their results. They had 137 cardiac arrests. 37 of them were PEA. 30 of those PEA patients had no cardiac activity on ultrasound. And of those 30, none of them had a palpable pulse. One actually was found to have a pulse by Doppler, but that might be just a false positive. 7 had cardiac activity. Again, all 7 were found to have no palpable pulse, and 5 were found to have a pulse by Doppler. So nothing too surprising. You probably do detect more pulses by ultrasound than by manual palpation. And ultrasound is not perfect either. You can have a false positive. But perhaps, again, the most concerning finding here is that 6 patients in asystole and 1 patient in VF were actually found to have a pulse by the person who was manually palpating. So I'm not saying POCUS pulse check completely replaces your manual pulse check, but based on the published evidence so far, I would say that POCUS pulse check is a very useful adjunct to your manual pulse checks. It's another tool that we can use to better delineate where this patient sits on the spectrum and better draw the line between whether that patient's alive or whether that patient is dead. And it's not something that's completely new to the people here, because according to the survey, about 30% of you have already done this during a PEA arrest. So let's talk about cardiac POCUS. This is something that's already pretty well established, I think, so I won't spend a lot of time on it, but I just want to talk about a couple of studies. One of them was this prospective observational study in 20 U.S. and Canada hospitals, and Mike Wu was one of the authors. And basically what they did was they took patients who came in cardiac arrest, and they did a cardiac POCUS at the beginning and at the end of the resuscitation. And they tried to see if cardiac activity on ultrasound was associated with survival. And so, as you can see from the graph there, if you had cardiac activity on ultrasound, your chances of survival were much higher. And if you had no cardiac activity, your chances of survival to discharge was less than 1%. They did multivariate regression and found that cardiac activity was actually the strongest predictor of survival. This was another study, a systematic review and meta-analysis of how good cardiac ultrasound is for predicting ROSC. And so they included 11 studies, and basically what they found was if you had cardiac activity on ultrasound, your chances of getting ROSC were 4.3 times higher than if you didn't. And as you can see by the forest plot, all the studies are in favor of cardiac activity predicting ROSC. So cardiac POCUS, especially in the setting of PEA, is an essential initial diagnostic test. And again, It's another tool that helps us better delineate whether this patient is actually alive or whether they're dead. And while people with cardiac standstill can still survive, we know that the numbers are actually very slim. So if they have cardiac standstill on ultrasound, we can place them closer to the dead patient end of the spectrum.
I will just start by drawing some blood. Well, isn't that odd? It's like poking through meringue.
No, try this arm. I saw some blood in there the other day.
Okay. So let's talk about arterial lines. I'm going to do my best Sebastian Dewhurst impression and ask you guys to consider this thought experiment. So you're working an evening recess shift, and you've just resuscitated a patient who came in with cardiac arrest. You got ROSC. The patient's intubated, they're sedated, their temperature is being managed in a targeted fashion. You have a keen junior resident with you who put in an art line, and you're on the phone with ICU, but the ICU senior says she's busy with sick patients in the unit, so she'll be a while. You say, okay, and you go over to eyeball the patient, and this is the blood pressure you see on the monitor. So what would you do? Probably nothing. Continue current management. So you go over and see a new patient. You go see a 90-year-old with syncope. She passed out while she was in the bathroom. And you diagnose situational syncope. But because she's 90 and lives alone, you're going to hold her overnight for Jem to see in the morning. But before you dictate your note, you go back to eyeball your ROSC patient. And now his blood pressure is this. So now what would you do? Any suggestions? Someone's using the POCUS. How about some fluids? Who would want to give fluids? Maybe a bolus of fluids? Okay. So you give 1 liter of fluids, and you go back to dictate your note on the 90-year-old with syncope. You know that you're handing her over, so you go through her home meds and order them for the morning. But as you're doing that, the nurse comes to grab you, and she says the ROSC patient is now dropping his pressure. And so now what do you do? Any ideas? Okay, great. That's the answer I was looking for. So you call for an infusion of norepi, and while the nurse is mixing that up, your monitor suddenly goes black, and so you don't have any information. And your keen junior resident walks by and astutely goes to the bedside to assess the patient, and he says there's no pulse. So now what would you do? How many people would start CPR? Okay, yeah, that's pretty reasonable. How many people would give a bolus of 1,000 micrograms of epinephrine? That wasn't a leading question at all. How many people would reconnect the monitor? Okay. Yeah, so now imagine if this patient came in his current state as his initial presentation to the emerge, and think about how you would manage that patient. So all this to say, an arterial line is perhaps the ultimate diagnostic tool for PEA in that you can definitively say where the patient is on this spectrum of disease. And not only does an arterial line to help you truly figure out whether the patient's dead or alive, it also helps you with what's called hemodynamic-directed CPR. So the idea behind this is that blood flow to your heart determines resuscitation success. And blood flow to your heart, also known as coronary perfusion pressure, is the difference between your aortic diastolic pressure and your right atrial pressure. And in all the studies that have looked at this, no patient with a CPP less than 15 has ever had ROSC. So the targets that we would want would be a CPP above 20, and the diastolic blood pressure has actually been shown to be a pretty good surrogate of CPP, so your diastolic should be above 30. And now, as an R5, I don't do much these days without Rosen's, so here's the Rosen's table, and this is from Chapter 8, the chapter on adult resuscitation, and what they say is CPP less than 15 or arterial diastolic pressure less than 25 are indicators of inadequate blood flow during CPR. So I think this just goes to show that this isn't some strange new concept of hemodynamic directed CPR. This is mainstream enough for it to be included in our go-to reference textbook. And furthermore, in 2015, the AHA guidelines also talk about this. So they say monitoring physiologic parameters during CPR provides valuable information about the patient's condition and response to therapy. So things like coronary perfusion pressure, arterial blood pressure are parameters that can be monitored continuously without interrupting chest compressions. There is evidence that these and other parameters can be modified by interventions aimed at improving CPR. And they go on to say in their recommendations that although no clinical study has examined whether titrating your resuscitative efforts to these parameters improves outcome, it may be reasonable to use physiologic parameters when feasible to monitor and optimize CPR quality, guide vasopressor therapy, and detect ROSC. So the take-home point here is that arterial lines help guide your management to PEA, and because of that, I think they should be high on your priority list when you're managing PEA. And again, this isn't something completely new. About 40% of those who answered this survey said they have placed an arterial line during PEA. And so I think this goes to show that this is something that's very doable. If any of you are feeling rusty about your art line skills, Dr. Mastoris invites you to do sim with him. So let's move on.
Not a bear in sight. The bear patrol must be working like a charm.
That's specious reasoning, Dad.
Thank you, honey.
By your logic, I could claim that this rock keeps tigers away.
Oh, how does it work?
It doesn't work.
Uh-huh.
It's just a stupid rock.
Uh-huh.
But I don't see any tigers around here, do you?
Lisa, I want to buy your rock.
So let's talk about Epi. So about 2 weeks ago, the AHA published an update to their guidelines in circulation, and they say we recommend epinephrine be administered to patients in cardiac arrest. On the basis of clinical trials, it is reasonable to administer 1 milligram every 3 to 5 minutes. Similarly, ILCOR, in the same issue of circulation, published their recommendations. They say we recommend administration of epi during CPR. For non-shockable rhythms, we recommend administration of epi as soon as feasible during CPR. So I've always wondered, how did 1 milligram of epinephrine become standard practice? And to answer this question, we have to go back to the 1960s. And this was one of the most influential studies on epi in cardiac arrest. And what they did was they took 70 mongrel dogs and they anesthetized them. They were intubated. And then the endotracheal tube was occluded. And at first, there were increasing efforts to breathe. Between 2 and 4 minutes after airway obstruction, the animals were apneic, and circulation then gradually deteriorated. And so they basically asphyxiated these dogs. And in some of the dogs, they started to ventilate, and then they gave 1 milliliter of 1 in 1,000 epinephrine injected into one of the ventricles. And so, as you can see from their results here, the groups that got epi did much better in terms of getting their circulation restored. Unfortunately, they didn't study any survival outcomes beyond ROSC, but based on this study and a few other animal studies at the time, epinephrine started to show up in guidelines. So this is from 1986. These were the CPR and emergency cardiac care guidelines that were published in JAMA. They say the recommended dose of epi is 0.5 to 1 milligrams given IV every 5 minutes. I find it kind of interesting that they say 0.5 to 1 here. The dose that was used in those animal experiments was 1 milligram. They don't really give a rationale as to why they recommend 1 milligram in the guidelines. If you think about it, the dogs in those experiments weighed about 10 kilos. So if you give 1 milligram, the dose works out to about 0.1 mg per kilo. But in a 70-kilogram human, 1 milligram works out to about 0.014 milligrams per kilo. So a few years later, people started questioning the dose of epi. And there were a series of trials that compared the standard 1 milligram dose to high-dose epi. And so this was one of the trials that was published in the New England Journal of Medicine. And you'll see some familiar names in the author list. In their introduction, they say, the currently recommended dose of 1 milligram for adults was derived from studies in dogs, but it does not allow for the large difference in weight between dogs and humans. I found it kind of funny that they had to provide a citation to say that dogs and humans don't weigh the same. So moving on to their results, the high-dose group compared to the standard dose group, as you can see, there wasn't a difference in their survival. And if anything, there might have been a trend towards harm in the high-dose group. And in the high-dose group, they used 7 milligrams of epi compared to 1 milligram in the standard dose. And so these results were similar to the other trials at the time on high-dose epi. None of them found a survival benefit, and if anything, there was a trend towards harm and a trend towards harm in neurologic outcomes as well. So after the dust settled, high-dose epi was out, and 1 milligram was still the standard. The evidence for the current guidelines revolves around a bunch of recent observational studies as well as 2 RCTs. For the observational studies, it's pretty consistent that epi improves ROSC and survival to hospital admission, but in terms of survival to hospital discharge, that part's more controversial, and epi to this day has never been shown to improve survival with good neurologic outcome. One of the RCTs that the guidelines are based on is this one. This one was from Australia, and it was randomized, double-blind, placebo-controlled trial. And what they found was epi or adrenaline improved ROSC and survival to admission significantly. In terms of survival to discharge or survival with good neurologic function, there was a trend towards benefit for epi, but these results weren't statistically significant. Now, the main criticism of this study was that it was underpowered because the study had to be stopped early. And the reason that the study had to be stopped early was because a lot of paramedic services in Australia at the time were refusing to participate. And the study actually got a lot of bad press, and politicians had to get involved, all because there was this big outcry of the ethics of withholding epi, which is quite interesting because the investigators obviously got REB approval, and all the data up to that time showed that there was no clear mortality benefit for epi. The other RCT that the current guidelines are based on was the Paramedic 2 trial, which came out last year. This was an RCT done in the UK, and they found that in their primary outcome of survival at 30 days, there was a statistically significant benefit for epi, albeit very small. The number needed to treat is about 125. The survival until hospital admission, again, in favor of epi. Survival until hospital discharge was also significantly better for epi. But if you look at favorable neurologic outcome at hospital discharge, there was no difference between the groups. So what this is saying is that more people are surviving until hospital discharge, but they're surviving in a neurologically unfavorable state. And same with 3-month outcomes. So believers of epi hailed this as a landmark trial, and this was the first large RCT to ever show that epi has a significant mortality benefit. Skeptics of epi say that this is further evidence to say that epi has never been shown to improve neurologic outcomes, and perhaps it argues against using epi because we have now survivors who are neurologically impaired. Putting it all together, this is what we know about vasopressors and cardiac arrest so far. So we know we need to target a coronary perfusion pressure of above 20. Vasopressors will help increase that coronary perfusion pressure. And epinephrine currently is the vasopressor that has the most evidence for benefit. So these are the things that we don't know. We don't know the optimal dose of epi. So as we said, the 1 milligram dose is based on animal studies in the 60s. High dose is not recommended because of all the negative high-dose trials. Low dose hasn't been well studied. There's actually currently a clinical trial that's ongoing with CanRock. Christian Valancourt is one of the co-investigators on that. So maybe in a few years we'll have results on that. We also don't know the optimal timing for epinephrine. One of the leading theories right now is that epi probably has the most benefit in the first 10 minutes of cardiac arrest. And beyond that, probably no benefit and maybe harm. And this is based on the idea that cardiac arrest can be split into 3 phases. The first phase, the electrical phase, in the first few minutes. If they have a shockable rhythm, electricity is the most important thing at that point. The second phase is the circulatory phase from 0 to 10 minutes. And that's when you need the blood flow to happen. And that's when epi is believed to have the most benefit. And beyond 10 minutes, you have what's called the metabolic phase. So your body experiences all the consequences of tissue ischemia, and epi at that point really exacerbates all of that by causing more peripheral vasoconstriction. And finally, we don't know if epinephrine is in fact the best vasopressor specifically for PEA with cardiac activity. There's not a lot of evidence to guide us on vasopressor use in PEA, but one of the alternatives to epinephrine would be vasopressin. And so for cardiac arrest in general, the AHA does not recommend using vasopressin. But the idea behind vasopressin and why it might help is that it causes vasoconstriction without a lot of the side effects of epi, such as increased oxygen consumption by the heart or ventricular arrhythmias. And vasopressin has also been shown to improve cerebral oxygenation in lots of lab studies. So there was one study about vasopressin in PEA, and this was a pre-hospital study from Slovenia about 10 years ago. And basically what they did was they identified patients with PEA, and they had paramedics do basically a cardiac POCUS. And if there was no cardiac motion on cardiac POCUS, they just went down their regular ACLS. If they found a specific reversible cause, such as tamponade, they would try to address that. But if they found cardiac motion with no specific cause, then what they did was they immediately gave 20 units of vasopressin. And then they checked for a pulse and then went down their ACLS if there was still no pulse. So what they found was, so with this protocol, they compared the outcomes with a historic PEA group. And what they found was the rates of ROSC were much higher, 94% compared to 54%. And the rates of good neurologic outcome are also much higher, 50% compared to 8%. Now, this is a very small study and had a lot of methodologic flaws, but I think the results are still interesting nonetheless. The other alternative to giving epinephrine is starting an infusion of vasopressors. And again, there's not a lot of evidence to guide us here, but there was one study on this topic, and this was done by the ultrasound group that did the cardiac POCUS study we talked about earlier. And again, Mike Wu was one of the co-authors. And so what they did was they had patients who presented with PEA. They excluded all the people with no cardiac activity. And out of the people who had cardiac activity on ultrasound, they divided it based on organized cardiac activity, so good contractions, and disorganized cardiac activity, so if the heart's just barely moving or twitching. And then they looked at what therapies they got. So they either got standard ACLS therapies or they got a continuous IV adrenergic infusion. So that was up to the physician, what agent they wanted. So the agents used were like norepi, epi, dopamine, even dobutamine, and even phenyl. So that wasn't standardized. And then they looked at outcomes for each group. So if we just look at the organized cardiac activity group, you can see that the continuous IV infusions of adrenergic agents had much higher rates of ROS compared to the standard ACLS medications. and that difference was statistically significant. In the disorganized cardiac activity group, there was no big difference. If we're looking at hospital survival, you can see that there was still a trend towards benefit for the people with organized cardiac activity and who got an IV infusion of pressors, but that difference was not significant. And again, hospital discharge, still a trend towards benefit for the organized cardiac activity and IV infusion of vasopressors, but again, that difference was not significant. So difficult to make any firm conclusions here, but still an interesting study, and I think it ties together a lot of the concepts that we've talked about today. So it just reinforces the idea that cardiac POCUS is one of our most important tools for prognosticating these patients. And if you see good cardiac motion on ultrasound, that patient is much closer to the alive end of the spectrum than the dead end of the spectrum. So the take-home point here is to consider alternatives to giving a 1,000 microgram epinephrine boluses in PEA with cardiac activity. And again, not a completely new concept. Over 50% of the people who responded to the survey said that they've already done this during a PEA arrest. So that brings us to the last topic of discussion today, which is what are your priorities in PEA? And this was also one of the survey questions, so we'll look at the results now. So number one was chest compressions, not surprisingly. And if you look at the top row, you can see how the distribution of votes were. So basically, 87 people said that chest compressions was their number one priority. 2 people said chest compressions was their number 2 priority. And then one person who really didn't believe in CPR said it was their number 5. Number 2 was epinephrine as per ACLS. And so about over 50% said that was their number 2 priority. And you can see a bit of variation after that in terms of how important epinephrine 1 milligram is. Number 3 was cardiac POCUS, and most people said it was either their 2nd, 3rd, or 4th priority. Number 4 was intubation, and again, you can see quite a bit of variation as to how people would prioritize that. Number 5 was vasopressors other than 1 milligram of epinephrine, and this is probably the intervention that had the most practice variation. Number 6 was an arterial line. Hopefully after today, this will move up in the priority list. Number 7 was central venous access, and number 8 was transesophageal echo. So after preparing for these rounds, I think this would be my approach for the next patient I see with PEA. So PEA obviously is identified with no pulse on palpation and an organized, non-shockable rhythm. So at that point, the first thing to do would be to start chest compressions. At the first pulse check, you need to do a cardiac POCUS. And if you see no cardiac activity on ultrasound, remember that places that patient closer to the dead patient end of the spectrum. I would just go through my standard ACLS, knowing that the outcomes are going to be poor. If you do see cardiac activity, at that point, I would ask a member of my team to start placing a femoral art line. At the same time, while they're on the femoral artery with the ultrasound probe, I would ask them to do a POCUS pulse check. If there's no POCUS pulse, then continue compressions, continue putting in the art line, and this is where you can do whatever you want with vasopressors. So it's totally defensible and reasonable to follow guidelines and still continue with ACLS and give 1 milligram of epinephrine. But I would say because this patient has cardiac activity, we know that they're probably closer to the alive end of the spectrum. I would seriously recommend considering alternatives to epinephrine. You can try vasopressin, you can try an infusion of pressors. But again, not a lot of good evidence to guide us here. So really, it's choose your own adventure. If there is a POCUS pulse when you check, and if you see a vessel that's non-compressible with active pulsations, then at that point, I would stop compressions, I'd continue placing the arterial line, and start a vasopressor infusion, or use push-dose pressors until your infusion is ready to go. And so in terms of ranking my priorities, chest compressions would be number 1, cardiac POCUS would be number 2, femoral art line would be number 3, and vasopressors would be number 4. In terms of the other interventions, I would say intubation would come next. We know pretty sure now intubation doesn't really affect the outcome of cardiac arrest, but it does have other fringe benefits, such as protecting an airway from aspiration. It can deliver O2 more effectively, so you can take hypoxia out of the picture, and you can also facilitate the next intervention, which is TEE. So TEE, as Rajiv talked about in his grand rounds a couple of years ago, can help us in cardiac arrest by giving you a better view of the heart. You can monitor CPR, you can monitor the response to your interventions, and you can help. It also helps you diagnose reversible causes. And after that, probably the least important thing would be a central line, if you have good peripheral access. Although it is sometimes difficult to get good peripheral access during a code situation, if you do have enough personnel on your team, a central line would definitely be a reasonable intervention. In terms of other monitoring, end-tidal CO2, this should be standard of care by now. Sean Chabra did a great grand rounds on this, and there's pretty good evidence to say end-tidal CO2 can help you monitor CPR quality, prognosticate the patient's outcome, and detect ROSC. And the other thing is pulse oximetry. So this is something that we don't normally think about, and there's not a lot of evidence for this in cardiac arrest. There's some animal studies that say it can help monitor CPR quality and detect ROSC, but I think it's a low effort, low risk intervention. You can just leave the probe on the patient's finger, and it could end up helping you. And so the take-home points again for today: PEA is a spectrum of disease. POCUS pulse check is a useful adjunct to manual pulse check. Cardiac POCUS is an essential initial diagnostic test. Arterial lines help guide the management of PEA, and consider alternatives to 1,000 microgram epinephrine boluses in PEA with cardiac activity. And finally, remember that we are the specialists in resuscitation, and we should be the experts of cardiac arrest. Sometimes it's easy to get nihilistic because the outcomes are pretty poor, but I really believe that PEA is one patient population where we can make a difference. We can use our specialized knowledge and skills and tailor our management to each individual patient. And regardless of what's written in journal articles, remember that it's what you do at the bedside in the resuscitation bay that matters. And remember that we own cardiac arrest. Thank you for your attention.